Welcome, everyone. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Today's program is a special collaboration between Blum Center and Mass General Cancer Center series. Oh, sorry, Mass General Cancer Center. Before we get started, just wanted to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted so that I can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff, our co-host and guest speaker will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we would like to ask you to help us complete. Your feedback is important to us as we plan future programs. All right, so next I'm going to turn it over to Devin Punch. She is the health educator for Mass General Cancer Center, and she will introduce you all to today's guest speaker.
Thank you, Amy. Thank you, everyone, for being here today. And a big thank you to Dr. Mary Morris. We're so glad to have you here today. Thank you so much. Dr. Morris is the medical director of the Fertility Clinic and the Reproductive Endocrinology and Infertility Division of the Department of Obstetrics and Gynecology at Mass General Hospital. She's also an assistant professor of obstetrics, gynecology, and reproductive biology at Harvard Medical School. Her primary research interests include exploring novel approaches to fertility preservation in those who've been diagnosed with cancer, as well as understanding clinical outcomes for women with hereditary cancer syndromes. Thank you so much for being here, Dr. Morris, and I turn it over to you.
Thanks very much for having me, and welcome, everyone. Let me just see. Do I need to share my slides again, or can you see my slides? Okay. It always takes me a minute. I'm so sorry. And I will apologize in advance for my lack of technical prowess. So today I'm hopeful that we can discuss some of the concepts related to normal fertility and reproduction. I do this for everyone who comes into my office because I think this is incredibly important for you to know what options are available to you. And then we'll turn to understanding the impact of chemotherapy and radiation on reproductive tissues, the ovary and uterus, and one that's oftentimes forgotten is the other part of the reproductive system, the female brain. And then we'll review what options are available to patients with cancer to preserve fertility. So I hope that everyone knows what they're looking at, but if you don't, this is the female reproductive tract, including the uterus, fallopian tubes, ovaries. Over here is the brain. That is, as I said, is the other important part of the system. So in women who have completely predictable menstrual cycles, cycle day 1 is the day that the period starts, so the first day of bleeding. Many of you may have heard of these two hormones called estrogen and progesterone. These are the female reproductive hormones. They get made by the ovaries. From the ovaries, they get secreted out into the bloodstream where they do their work on all the other tissues. It turns out that the levels of these two hormones fluctuate in very predictable ways in women who have very predictable menstrual cycles. So if we're to measure the levels of these hormones on day 1, they're their lowest levels of them. So hormonally, when a woman has her period, is actually a very quiet time. Even though the ovaries are hormonally quiet, they're doing something else that's important and dynamic, meaning that of the thousands of eggs that are in her ovaries, a handful of them are going to get into a competition and try to ovulate for the upcoming month. You can't see eggs, they're microscopic. Once they get into the competition, you can see a little fluid-filled sac forms around those particular eggs, like I'm pointing to. And those structures are visible, and they're called antral follicles. So if I were to do an ultrasound, I'd see a whole bunch of structures like this scattered throughout both ovaries. What they're competing for is a hormone from the pituitary called follicle-stimulating hormone, or FSH. A woman's pituitary makes this hormone all the time in really tiny amounts just before she gets her period. Her brain gets a signal to increase the amount of FSH. So now that hormone is going to feed down through the bloodstream in great enough amounts. These start to compete for it. Over the course of a few days, one of them starts to win. And when that happens, the cyst around that one gets bigger. When it gets bigger, it produces estrogen. The bigger it gets, the more estrogen it makes. So estrogen starts to prepare this lining of the uterus for pregnancy. It also feeds back to the brain and causes it to lower back down the FSH. When the FSH drops, the small ones that are not winning start dying off. This one now continues to get bigger and bigger, making more and more estrogen, till finally the estrogen's high enough for long enough. It causes the brain to turn on another hormone, which is called luteinizing hormone, or LH. If you're familiar with those ovulation predictor kits, that's what people are measuring in their urine. So LH now floods back and talks to the cyst and causes the egg inside to mature over the next several hours, and finally for this egg to ovulate. So one egg ovulates, and it lands here in the fallopian tube. The cyst remains behind, now produces progesterone and estrogen, which further prepares its lining. So during heterosexual intercourse, sperm gets deposited in the vagina, most of it falls out. If you're trying to get pregnant, you're super lucky. The sperm will find their way out to the fallopian tube. Egg and sperm meet up. That's called fertilization. This is now called an embryo. It's going to spend 5 days traveling back through the fallopian tube. If it implants, it produces a hormone called HCG. HCG gets in the bloodstream, keeps the cyst alive. Estrogen, progesterone from the cyst keep the pregnancy alive. They get into a mutually beneficial relationship until about the 10th week of pregnancy, when the placenta is formed. If there's no pregnancy, there's no HCG. And if there's no HCG, the cyst dies off. And when the cyst dies off, the estrogen and progesterone levels drop. Fall in estrogen and progesterone levels cause flying to shed. So that's the period. Fall in estrogen and progesterone is what causes the FSH to rise again, and the whole thing starts over. I'm not going to test anybody on this, and I don't expect anybody to remember it, but part of running through this helps set the stage for the third part. The other thing is that to point out, this is really hard. Humans are not good at this process. So if I were to say, take 100 representative couples and say, just try to get pregnant, in the first month, only about 15 of those 100 would get pregnant. In the second month, another 15%. In the third month, another 15%, fourth month, 10%, fifth month, 8%. Each month it drops off a little bit more. Finally get to the 12th month, 2% will get pregnant. When you get to the end of the first year and remove everybody's gotten pregnant, you're still left with 15 out of those 100 couples. And that's the medical definition of infertility: inability to achieve a pregnancy after 1 year of unprotected intercourse. When we look at these couples, there are 4 things that we can diagnose. One is a male factor. So yes, chemotherapy and radiation can impact male infertility, but that's not going to be the topic of today's topic. And if anybody wants to talk about that, we can at the end. Another is anatomical issues. Again, not sort of a problem for most patients who are walking in the door who've been diagnosed with cancer. The third is really what is on their mind. And this is problems with ovulation, ovarian reserve, and hormonal issues. So that's what we're going to focus on the most. So this is a graph that shows the number of eggs that a woman has by age. And you can see that the first half of the graph is when you have the most, and this is before you're even born. You have the most number of eggs. This says more than 5 million, but it's typically about 5 million at 5 months or 20 weeks in utero. And eggs are starting to be lost from those ovaries before birth occurs. By the time a girl is born, she's down to about 1 million of those eggs. And many of those are lost through that competitive process that we were talking about over the years. By the time she starts ovulating around 11, 12, 13 years old, she's down to 500,000. Will ovulate about 500 of the 400 to 500 of those throughout her life. So chemotherapy targets rapidly growing cells and dividing cells. That's what cancer is cell growth out of control. Oocytes, as I said, they're just sitting waiting for their turn, so they're quiescent or quiet. So nobody's quite sure why chemotherapy destroys oocytes, but we know that it does. Radiation has local effects primarily. Surgery is usually obvious. It's if you have to have an ovary removed because of cancer, obviously you're going to have far fewer eggs than you started with. But the big question is why chemotherapy impacts ovarian reserve, and the answer is we don't know. It's thought that perhaps the support cells of the ovaries, ones that nourish those eggs while they're waiting for their turn, are growing and dividing. They're killed, and the egg is an innocent bystander of that cell death from chemotherapy. So I stole this from a resource called Up to Date, so you can see it referenced down here. Really, not all chemotherapies are created equally in terms of their damage. It depends on the class, the amount, combination, patient age, and ovarian reserve. It tends to impact women who are more mature than it does younger women. And there's almost nothing known about some of the newer agents that some people are on, such as the tyrosine kinase inhibitors and antibody-based agents and some of the immune modulators. So that's a very active area of research. Radiation is incredibly damaging, much more so than chemotherapy. It can also be damaging to the uterus, and typically pregnancy is contraindicated. Head radiation can affect the reproductive cycle hormonally. So if you have impact to your pituitary. And I will also add that I know a lot of people who come to MGH, they're here because of the proton therapy, also because of the wonderful oncology teams, but the proton therapy is not available at most hospitals. And the impact of proton therapy on all of these is also unclear and should be investigated further. So the options for family building are as follows: conservative. There can be medical management, and that's an area of active investigation at MGH that we won't talk about today. But again, if you're interested, we can maybe address it then. The gold standard is oocyte and/or embryo cryopreservation. There's also availability of ovarian tissue cryopreservation, and there's oocyte donation and/or gestational carrier and adoption. So I'm going to run through each one of these. Conservative management really needs no explanation. There are numerous registry studies in children and young adults treated with cancer and show that they have a higher rate of ovarian failures than their siblings and have fewer children. The good news is they also show that they are not at increased risk of having a child with birth defects or childhood cancers. Once you are through this, the eggs that survive, and they are no worse off for what you've been through. And I hope that provides a lot of reassurance. The fact that some people don't have as many children as their siblings could be also time impact and also social and psychological impacts of fear. Medical management, there is something called that some of you may have taken or been offered. They're called GnRH agonists. They work at the level of the hypothalamus and the pituitary, so those brain parts that are responsible for production of the FSH and LH that I talked about. The principle behind this is that if you shut this down, then the ovaries will be quieter. And if the ovaries are quieter, then they'll be less impacted by chemotherapy. It's a tremendous idea theoretically. In practice, the literature is all over the board in terms of its ability to help with different types of cancers and showing different outcomes. The studies generally are not well done. They're mostly retrospective, which means that there's sort of a bias of selection. So many of my patients will take it, but I just have to tell them that there's not a whole lot of data to support its use in terms of fertility preservation. It does provide some convenience because it does shut the menstrual cycle down at a time when someone could be anemic and also have low platelets and therefore be at risk for heavy bleeding during a period. Surgical management. So there is controlled ovarian hyperstimulation, which many of you might have some idea about. It's an IVF cycle for embryo banking and oocyte banking, and then ovarian tissue cryopreservation. And the IVF is the reason I ran through that sort of normal reproduction. So it's called controlled ovarian hyperstimulation. Getting prepared to do in vitro fertilization actually means getting egg and sperm together in a dish. The process leading up to it is where we get a whole bunch of eggs and you take medications which are purified FSH and LH. This was a tool for patients with infertility to overcome the obstacles and inefficiencies of reproduction, and it's based on the physiology of the normal menstrual cycle. We are repurposing this tool And for patients with cancer, it provides an opportunity, but it's not a perfect science for either because of the tolerability and side effects, and also the lack of guarantee of outcomes. So the first IVF cycle was for tubal factor infertility. And basically what they did, this was the first success was in 1978. They took young women who were in their 20s, because that's back in the time was when women started trying to build their family. And they basically just went in and rescued that ovulating egg surgically. And then they combined it with sperm. And the thought was, in a 25-year-old woman trying to get pregnant with no barriers, her probability of success in the first month would be 40%. And they thought, well, this 25-year-old, if we get that egg, combine it with sperm outside the body, get that embryo back in, it's going to be about 40%. Turns out it was more like 5% success rate. And we got incrementally better at this as we incrementally understood the process that I described to you better. The real success, though, in IVF and modern IVF for people with infertility and also for cancer patients were two pieces of information. 30% of human eggs that ovulate are not fertilizable. It's no matter what your age is. 30% of the time when a woman ovulates, it's not a fertilizable egg. That egg that wins is no better than any of the others. Of the 70% that are fertilizable, the fraction that are chromosomally abnormal rises with age. And this is, people often talk about the age 35 as being important in women's reproduction. The age, that's the age at which the slope of that curve of the 70% is going up, right? So a 25-year-old, I said, has a 40% chance of getting pregnant. A 42-year-old has, in any given month with no barriers, a 43-year-old, let's say, would have a 2%. And so that 15% per month that I talked about averages the 25-year-old with the 40-year-old. Modern IVF, to take advantage of these two facts, basically we just use medications to rescue the eggs that would have been lost anyway. And one of the questions that I often get from my fertility patients is, are you stealing eggs from the future? And the answer is no. I'm just rescuing up those that would have been lost anyway. And so what this process looks like after a woman has taken, she basically takes 2 weeks of injectable medications and a variety of different types of them. It's usually 3 medications for 2 weeks. She comes in for 5 or 6 10-minute appointments over the course of those couple of weeks. And this is what the ovaries look like at the end compared to what you'd seen in the prior slide. So many of these follicles have gotten big, not just one. And what you can see here is an ultrasound probe in the vagina, small needle sits on top of it. It's just a little bit, about the same size that we use for a blood draw or an IV placement. And she undergoes an egg retrieval. That's day 0. So we get a whole bunch of structures that look like this. This is what a mature egg would look like. We can grow, these can be frozen right here, or a process called vitrified, or they can be inseminated and we continue to culture. And this is what's called a 2-pronuclear embryo. This is just as the egg and sperm nuclei meet, and we can freeze them there. We can also go on to culture them, and you get this is a beautiful day 3 embryo. It's got 8 cells in it. Or we can continue to culture and generate a blastocyst. And these also can be frozen. Our common places for freezing are eggs, the 2-pronuclear stage, and the blastocyst stage. And there are a variety of reasons to select one or the other of these stages. And this is the reason, is that a certain number of oocytes, if you're a 25-year-old woman and you have 10 eggs, I'm going to anticipate 7 of them fertilizing normal, and then some number of those embryos don't survive in the dish. Some of those that do survive that are implanted, that get placed inside the uterus don't implant. And sometimes when there's implantation, there could be a miscarriage. So the live birth rate is even smaller. And then when, there is some survival rate for the first year. And so there's this attrition. It's sort of like an upside down iceberg. And so in order to get a live birth, you have to start with a lot of eggs. 15 years ago, if somebody with cancer, and my first cancer patient was a little less than 15 years ago, she walked into my office and she was a 32-year-old graduate student at MIT. And I'd never taken care of a patient like this before. I was a fellow, and it struck me that we didn't really have an organized way of taking care of her. And she literally was my inspiration for doing this. Freezing eggs at the time was not a good technology. And the reason is that I'm sure all of you are familiar. If you go to the grocery store and buy, let's say, a whole chicken or pieces of chicken, and then you buy a crate of eggs, and you decide, well, I can't eat all of this at this point, I have to put something in the freezer. Intuitively, everyone will put the chicken in the freezer, right? Because they know that it's going to come out on the other side okay. And the same thing was true, that embryos were multicellular and there was much less damage to them. So it was okay to freeze an embryo. We've been freezing embryos since 1984 and having live births. But freezing eggs was a terrible technology. And what we learned through the years is that we shouldn't be freezing them. We use a process called vitrification. And so, I'm so sorry I didn't put the reference for this, but it's down here, so it's there. That we remove all of the water in the egg and replace it with, believe it or not, ethylene glycol, which is the standard antifreeze it's the same thing that you use in your car engine, right? It's sterile, it's processed in a different way. But this really, really improved our success rate. So if you look at this graph over here, if you are a woman between the age of 30 and 34 and you freeze your eggs, and let's say you have 30 frozen or vitrified eggs, I'll use the terms interchangeably, you can expect there's a 90% chance that you'll have a baby using those eggs. If you say want 2 babies out of that lot of 30 eggs, I'm going to tell you it's about a 70% chance. And if you want 3 babies, it's about 45%. And these are live births. What you can see as a woman gets more mature is that these curves start to fall down, right? They get lower and lower. So in this age group, it's much more challenging than it is for a woman who's 30 to 34. The other thing to know is that if a 34-year-old walked into my office, it's typical for her to have 30 or 40 antral follicles. And I will tell her we'll get about half to 2/3 of those because that's the way it works. So we'll get maybe 20 eggs, and it still gives her about an 80% chance of having a baby. A typical 41, 42-year-old is going to have about 4 to 6 antral follicles. So if we get half to 2/3 of those, we're really talking about less than 10% chance of that happening. And therefore, if somebody has cancer, yes, we will freeze their eggs if they're 41, 42, but I do try to point out to them that, their probability of success is going to be quite low, which can be quite discouraging to people sometimes. But, I think it's important to be informed. Ovarian tissue preservation is probably the newest technology. It is not available everywhere. It is available at the MGH. It is a surgery in which we remove all or part of the ovary. It then gets cut into strips and slowly frozen. So you remember I just talked about freezing eggs being a terrible technology because we used the same technology, which was the slow freeze technology. And it works well for tissue and for blastocysts, but unfortunately, most programs moved over to completely vitrification and gave up slow freezing. And then ovarian tissue cryopreservation started to take off. And unfortunately, most programs have given up the slow freezing technique, including ourselves. So what we do here is we harvest the tissue and it gets shipped to the Brigham for the freezing process. And believe it or not, it's viable for a long, long time. And in fact, in Europe, sometimes there's a 3-day transport process that is involved. And some of these tissues have still worked despite being 3 days in transportation. It's a very short trip over to the Brigham. We carry it ourselves. We don't entrust anybody else to it. One of our embryologists will take it over and hand it off to the Brigham team directly. And it gets saved. and it can be reimplanted to bring on puberty. So beginning of the menstrual cycle, if say, for example, someone has not yet started their period and they reach a certain age and they have it, and we deem it to be due to ovarian damage from the chemotherapy, we just go back to another surgery and stitch those back in on the remaining ovary. It can be used to restore ovarian function, to get rid of menopausal symptoms in someone who's premenopausal, or for fertility purposes. Thus far, it has a low use rate. Registry studies show that about 8% of people who frozen tissue have come back for it, and in programs that record this. And I say this with a little bit of reservation, a high success rate for restoration of function and live birth rate. Of those who have reported, there's an 80% restoration of function and a 60% live birth rate. But my grain of salt takeaway from that is that probably many programs, if they don't have success, are not reporting. So I can't say that I universally believe this. These are just for programs that are reporting. Other options include oocyte donation. Many people will use known donors, for example, a sister or cousin or friend. There are anonymous sources, both agencies where you can get an anonymous donor and get all of the eggs. And that sometimes can be advantageous for a young woman who wants multiple children, meaning that if she gets 30 eggs, you get all of them. And there are also frozen donor banks. It's cheaper for using a frozen donor bank, but the major disadvantage is it usually comes in lots of 6 to 8, which lowers the probability of success because you just have fewer eggs. For people who have had hysterectomies or who have, say, for example, breast cancer and are going to require endocrine suppressive treatments like tamoxifen or Lupron for several years, you can use a gestational carrier. There is also option for adoption, which my understanding is, as I've been doing this and, run through this with not just cancer patients, but bread and butter infertility patients, the adoption process has gotten harder and harder. Certainly international adoptions from China and Russia are getting harder. The other thing is that there's a bigger push to keep children with biological relatives, and so it has become much more challenging. What's the right choice? I think it's very dependent on the situation. Some chemotherapies or surgeries need to be done urgently, and certainly a patient's safety is everyone's first goal, myself included. It is important to be informed, and it is important to feel good about your decisions. Regret is something that I don't want anybody to have, and I do think having the conversation is important, even if you know that you're not going to be able to go to uptake one of these that you might have wanted to if you'd had time otherwise. But I think it's important to have the consultation because you can go back and to yourself and go, oh yes, I do remember I was very, very sick, or my oncologist very much felt that this was important to start, and have that discussion with yourself so that you won't have any regrets. It is a support service. It's elective. I want this to feel as low a pressure as possible. There are a lot of high pressure, high stakes consults that you're having when you have been diagnosed with cancer. And really the goal is to focus on the future and potential. There are many ways to build a family. Different people have different levels of comfort with these technologies, and I think even more so in today's world. One of my favorite stories was from NPR many years ago. I know many of you, if any of you have heard me talk before, that the story was called The Modern Family, and it was a man and a woman who had both had one child. They each had divorced. They found each other and remarried, and they decided, we have such a wonderful family and so much to give, we can adopt a child. And around that same time, they got pregnant accidentally, And so they went from having 2 children to 4 children. And many years later, on a Father's Day, they took the kids to visit the woman's father. And then many years later, the woman was looking at this picture and said, "Oh, isn't that funny? Julia has my father's smile." So her grandfather's smile. And then a few days later, she went to the picture and she said to herself, "Oh, that's really funny because Julia's our adopted child." And it was interesting that she felt like the one who was most like her father was the adopted child. And so I think it speaks a lot. Our genetics person here did the math one day, and she said, I realized that my great-grandchildren will only have 2% of my genes. And so it's more than our genetics that make us parents, right? And so I think it is, just a moment to sort of pause and think about that. And this is contact information. I ask any of you who do decide to have a consultation, vet it with your oncologist. I'm sure all of them will say yes, but it makes the consultation a little more formal. And it also puts it on my radar screen. If you do call either one of these numbers, you're going to make your way to what's called a call center if you say you're a new patient, and that's not the right place for you. You have to tell them you have cancer and you need to be redirected back to the office. And that's one reason telling your oncologist will generally reach out to me. But the system's not perfect, but the squeaky wheel does get the grease. So just be persistent. For most people with cancer, a consultation 3 weeks from now is not acceptable. There are many, many websites. Our own website you can go on to and look at. There's also the Society for Assisted Reproductive Technology, which helps you understand outcomes. The Livestrong Foundation has a great website in terms of understanding. And then I will wrap up by just saying thank you and see what questions you have for me.
Thank you so much, Dr. Morris.
Of course.
This wonderful presentation, very informative, and I hope it's helpful to so many of you listening today. If you have any questions, we do have some time for them. You can put them into the chat box. One that's come in: how do these options differ for patients who've already received chemotherapy compared to those who are thinking about these options before starting treatment?
Yeah, and this is sort of tricky. Let's imagine you've gone through chemotherapy and then you're struggling to get pregnant. You would just set up consultation with myself or one of my colleagues, and it would be very similar to a routine infertility evaluation. Or if you're interested in freezing eggs after the fact. The unfortunate part of insurance is that they will pay for it prior to chemotherapy, but they will not pay for it once chemotherapy is complete. And so that does make it a little bit tricky in terms of the financial piece of it. And I think it's a little bit unfair, or it's a lot unfair, because before chemotherapy, you're kind of rush and focusing on a lot of other things. But it is the exact same evaluation that you would go through. It's mostly ovarian reserve. And if you're trying to get pregnant, the evaluation consists of all the things that I talked about: a semen analysis for male patients, a fallopian tube test for women, ovarian reserve testing, and then other preconception tests like making sure you're immune to rubella, varicella, checking HIV, and all of those things.
Do you recommend patients undergo ovarian tissue preservation before, during, or after cancer treatment?
That's also a great question. Generally, we recommend it before, because the damage is being inflicted by the chemotherapy or the radiotherapy during and after. That is a bit of a tricky issue, though, because you're taking a tissue out before chemotherapy or radiation, and then you're putting it back, and that tissue has not been treated with the chemotherapy or radiation. And for, say, breast cancer, the first place it metastasizes is to ovary. And for hematologic malignancies, for example, leukemia, those cells are circulating, and so the ovaries haven't been treated. The hope is one day, so tissue preservation is primarily reserved for people who don't have time. For example, if you're very sick and you're going to have your port placed, we can take an ovary at that time. People who've not yet started their period, because you can't go through egg freezing or embryo freezing, which are the gold standards. And for people who have solid tumors that don't generally metastasize, but they're going to need, for example, pelvic radiation.
And you touched a little bit upon this, mentioning patients that have not yet had their period, but for parents whose children are undergoing cancer treatment, are there other considerations or things that they should be speaking to their child's doctor about, or other sort of things in that realm?
I think this is one of the trickiest things that I've run across, because I think children and their parents have very different motivations, and parents have the long view and children don't necessarily have the long view or know what their desires are in terms of having children in the future. And so the youngest patient we've done ovarian tissue cryopreservation was 6 years old. And she seemed to have a good understanding of what we were doing and why. But I think the parents were more the motivating force behind it. The youngest I've ever heard about it happening to is a 2-week-old. There was a case in Chicago, and I'm sure there have been younger ones, but that's just one I've had a conversation about. It does raise issues of, what is informed consent and assent. Many parents are opposed to it because, they don't want their child to have another surgery. They don't want removing a reproductive organ can feel wrong for a parent. And so I think they're very different conflicting issues. And I think you just kind of have to talk to everybody who's involved and come to some conclusion about what the best thing is for them. And for example, I was talking to a father the other day of a girl who literally just started her period. I don't think egg freezing would have been an option for her because she was so young. And he was really relieved to hear that, her sister could donate eggs for her in the future if she needed to. Maybe that would be their opt, if they needed it.
So I'm sure it's helpful to have clinicians in your role to kind of help people explore what those options may be going forward, things that they might not have thought of initially.
And I turn a lot to social workers, a lot. They form a big role in this place because, they sort of help people tick through their priorities. And, it's incredibly helpful to have people organize their thoughts. This becomes a big sticky mess emotionally. And if you can have somebody who can help you sort of pull apart the stickiness or take the stickiness out of it and make it a little more logical, I think that's important.
Definitely. So if there are any more questions, feel free to type them into the chat box. Does the MGH Fertility Center work in partnership with oncologists when a patient is seen at the fertility center, or how does that sort of dynamic and collaboration work?
Usually I get my referrals, not necessarily from the oncologist, but from the nurse or the social worker. And I have communication with the oncologist. Usually I talk to the oncologist before I see the patient. One thing I went before COVID, I actually had a clinic down in the cancer center that I was in once every 2 weeks. That clearly wasn't enough frequency to see cancer patients, but it was a reminder to the oncologist that I exist, and oftentimes they see me go, I have this patient, I should refer them to you. So I think it was a good thing. Now that COVID has happened, we don't do that anymore. One thing I'd love to see, and this is a bigger MGB, it's bigger than me, but a couple of times I've actually seen the patient with the oncologist, and I realize that's impossible because of everybody's scheduling differences, but it's really, really helpful to be able to do that. And everybody can sort of get their plan out and everybody knows who's responsible for what and what our time frame is and what our goals are as a team. But we do as much of that through the Epic messages and mostly, and sometimes still email. But I really do want everybody's goals to align.
Absolutely. Could you talk a little bit about what services and options are available for men going through cancer treatment?
Yeah, so, you know, for post-pubertal men and boys, they can come here to freeze sperm. We have a certain relationship with the FDA because we do third-party reproduction tissues, you know, egg donors and gestational carriers. So we have to check HIV and all of those labs on everybody and have them on file at the time that the sperm was frozen, because that's part of our storage agreement with the FDA. It can be much simpler for both inpatients and outpatients to use one of the commercial banks. It's actually cheaper as well. So New England Cryogenics, California Cryobank, Reprotac is another one. You just call the bank, and for inpatients, there's some paperwork that can be filled out, and the bank actually can come and pick it up. For outpatients, you just go to their center, and again, it's easier and cheaper to do that. Pre-pubertal boys, it's a little bit trickier. There is no sort of standard of care for testicular biopsy, and there's no proof that that works at this point. There is a urologist at Children's Hospital who does this, but I don't know of anybody here at the MGH or at the Brigham or any other institution that does it. His name, I don't recall at the moment, but I could come up with it if somebody's interested.
Thank you. We have some more time, so if there are any other questions, feel free to type them into the chat box. And I guess we can just give it another minute, and if there are no questions, we can wrap up. But is there any sort of emerging or interesting, fascinating kind of research in this area that is worth kind of talking about for a minute or so?
Several, but I can tell you about what stuff that we're doing here. I collaborate with the pediatric surgical group. There's a researcher here by the name of Patricia Donahoe. She's an amazing woman. She was the first woman chief of service ever at the MGH, which I just think is extraordinary. And another person who is in the laboratory named David Pepin. And they work on this molecule called Mullerian inhibiting substance, also known as Antimularing Hormone. This is a hormone that's made by the ovaries, and it's produced by, so as I'd mentioned, there's several types of follicles in the ovary. They're the resting ones. Then they're the ones that are sort of getting into the action. Then there's the competing ones that, you know, I said were the ones that you can see. And then there's the ones that are near ovulation. And this hormone is made by the follicles that are just getting into the action. So before you can see them, but the ones that are not still resting. And it's thought to put a negative feedback on the ones that are resting. So it prevents them from getting into the action. So this is the way ovarian reserve is maintained in animals. And so they actually made a serendipitous discovery when they were giving mice who had cancer chemotherapy, is that when the chemotherapy, they were giving one group of them control substance, they were giving one group of them anti-Mullerian hormone. And when the experiment was over, they were looking at the ovaries of these mice, and the ones that just got chemo, the ovaries were just, you know, gone, no follicles left. And the ones that they'd given AMH to, and this wasn't even what they were supposed to be looking at, still had reserve. And so it's thought that, you know, when I mentioned that those hormones that we give to suppress the ovary to keep them quiet, the ones that we use don't work, but this one would work. And so we've gotten to the point with, you know, it's primarily their project. I'm their clinical consult, but there is a biotech company now that is experimenting with, you know, getting this to a clinical phase, and it is now being used in monkeys to see if it would be in primate model, to see if it's been replicated in cats. And so one more animal model before it can be presented to the FDA, hopefully as a treatment, as a clinical trial. but I'm very excited about this work. Obviously, if I could give somebody a medication, or they could take something every day, or we could give them one shot of it, and it would prevent them from having to go through IVF or do any of this stuff, that would obviously be a great goal. But that's sort of the 5-10 year window.
I was going to ask if that was something that did come to fruition, how far into the future would you say that it seems like it would be?
If you had asked me 2 years ago, I would have said it's pie in the sky and maybe never. But several biotech companies had sort of sniffed around the project, and one latched onto it and decided this was a priority. And it does take someone who's primarily interested in women's health. The bigger drug companies sort of have a everybody model, and this is a women's health group. So I think that that's why it was a priority to them.
Great, thank you. Looks like we don't have any more questions. Unless there's any final words you have, Dr. Morris can share them. Otherwise, thank you so much for being here today. And thank you, Amy, for hosting, and everyone else for joining.
Well, it's absolutely my pleasure, and I always enjoy doing these. And so I appreciate the opportunity.
Thank you again, everyone. And just as a reminder, the webinar has been recorded and it will be posted to the Blum website.
Thank
Have
you
a great
so
rest
much.
of your day.
Bye.
Bye-bye.